Okay, good evening, everybody. Welcome to our IRA webinar series. We are with update on lupus, and is the second component. Yesterday, we had the first component of lupus. And even with this pandemics of corona, we could manage to maintain the academic flavor. And we are having the beautiful contribution from the national and international delegates. And today we are having the moderator, Dr. Rohini Shamant from Mumbai, and Dr. And Namisha Patel from Ahmedabad. And Rohini is a consultant rheumatologist at PT Hinduja, and Namisha is in Vadodara, consultant rheumatologist. So both of them will conduct. We have with us Professor Lisa Rajsekhar from Nizam Institute, Hyderabad. Professor Ramnath Misra, he was the past president, Indian Rheumatology Association, former dean, SGPGI Lucknow, former professor and head clinical immunology, SGPGI. Ranjan is with us, he's a product from SGPGI, now in AIMS faculty. And we have with us Professor Anishur Rahman. Everybody knows him with his brilliant contribution for the last couple of years in lupus meeting in India. And he has a great contribution in lupus science, especially in APS. So we'll enrich ourselves from their knowledge. So may I request Dr. Namisha and Dr. Rohini Shamant to take up the podium and to initiate the program. Thank you.
Thank you, Professor Ghosh, and thank you to IRA for choosing us to be moderators. This is the second part of the third in series of IRA webinars as a part in lieu of the IRACon, which will not be held this year. We had the first part on lupus yesterday, which was an interesting session. And we heard that lupus with its myriad manifestations at times lands the patients land with life-threatening flares. The lupus tends to affect women in their childbearing age, and though fertility is not an issue, pregnancy itself can pose difficult and interesting questions for the patient and the treating doctor. So for the first talk, which is on lupus pregnancies, improving outcomes, we have Professor Lisa Rajsekhar. She is professor and head, Nizam's Institute of Medical Sciences in Hyderabad, the department there, she heads it. She's keenly involved in optimization of patient care and outcomes of rheumatic diseases. Her research interests include lupus, myositis, and vasculitis. She is going to enlighten us and bring us up to date with lupus pregnancies, improving outcomes. Professor Rajsekhar.
Thank you, Dr. Namisha. I would like to thank the Indian Rheumatology Association, which is being represented by Dr. Alakendra Ghosh and Dr. Sapan today in these times of pandemic, to give me this privilege of talking about one of the most clinically challenging areas in lupus. And this privilege is well received by me, and I hope that I can do justice to this topic. Before we go too much into the details, I would like to, in the next couple of slides, refer to a few housekeeping points, which I think everybody knows. And this is that high disease activity when we are faced with in a lupus patient who is desirous to have a pregnancy, then our focus is only to control the disease activity and to inform the patient that she will be reassessed for planning a pregnancy when the disease is quiet or quiescent. If we are faced in the clinic with a patient who has low lupus disease activity, then our focus remains to change the therapy to pregnancy compatible medications and to observe then on these medicines for efficacy and tolerance, and then give the green signal for going ahead with a pregnancy. These are caveats which are well known to all of us. The third important housekeeping thing in managing lupus pregnancies is that there is absolute contraindication to pregnancy in lupus in the presence of severe organ dysfunction, which is either in the kidney or in the heart, or in the lungs. Having looked at these uh, points of view, then there are many, many patients and many, many scenarios which we face in day to day life. When we counsel the patient in the clinic, then the goalposts which need to be visualized in our mind is what are we looking at for the mother in the short term at the end of this pregnancy? What are we looking at for the child? And in terms of handling the current pregnancy, what are we looking at the long term maternal outcomes in the mother and the child? With these four goalposts in mind, I would like you to just uh, bear with me as I share with you this case, which was published in the Journal of the American Society of Nephrology, where they showcased the electron microscopic findings in a 31-year-old woman with lupus who had lupus for 10 years and who presented at 6 weeks of gestation. Before pregnancy, she was on a daily dose of prednisolone, hydroxychloroquine, warfarin for APS and lupus. And at her first visit, at conception, the prednisolone was continued, the warfarin was changed to dalteparin, and hydroxychloroquine was discontinued. At 12 weeks, she had chest pain, shortness of breath, worsening proteinuria, acute kidney injury, and the renal biopsy showed on EM a membranous glomerulonephritis. Consequent to this, her prednisolone dose was increased, the hydroxychloroquine was restarted, but within 3 weeks, she had a massive pulmonary embolism. And despite a lot of resuscitative efforts, including continuous RRT, there was a bad outcome for the fetus as well as for mother. I'm sure that many of us have had such experiences like this with patients of lupus. And with this in mind, that the challenges can be as bad as this, I would like to cover certain areas in my talk. And using the latest guidelines which have been published by the American College of Rheumatology, I would like to talk about contraception, assisted reproductive therapy, lupus nephritis, antiphospholipid antibody syndrome in pregnancy, and what drugs are safe in pregnancy. Now, if you look at this slide and refer to the rightmost column, which describes the typical use failure rate in patients in contraceptive methods, and this is the data from the general public, then you will notice that the pregnancy rate with no contraception is as high as 85%. With the use of barrier contraceptives like the male and the female condom, the pregnancy rate falls to 9% when you use combined oral contraceptive pills. But the success rate of contraception increases remarkably with devices like the progesterone IUD, the progesterone subdermal implants, and obviously the female sterilization. In a progesterone only pill, the failure rate is very high, to up to 9%. On the middle column is the perfect use failure rate, and this will obviously be a little better than the typical use failure rate. Keeping this in mind, it is important that to note that a good practice statement means that the best thing to do in the clinic is to discuss contraception at the initial visit in every woman of the reproductive age. Due to the social cultural issues that we have, we often have an inertia to discuss this with uh, single lupus women, and especially those who have just transitioned from into adolescence and into early reproductive age, and especially in those who are not yet sure when they're going to get married. However, it is important that we start this process, we remove the inertia in the mind, because I'm sure that each one of us has faced a situation where patients are lost to follow up and they come back stopping all medicines and not knowing that it would have been good to use contraceptive measures for some time. If nothing else, barrier methods should be recommended. There is strong recommendation for two things. One is there should be emergency contraception in all patients if required, because the risks for unplanned pregnancy are much higher. Intrauterine devices, either copper or levoprogesterone IUDs, or the progesterone only pill is recommended in patients who have antiphospholipid antibodies. And those who are in this situation, definitely the combined oral contraceptive pills are not indicated because they have a very, very high risk of causing venous thromboembolism. In lupus patients, we avoid the estrogen patches. We prefer an IUD, whether it is a low disease activity or is a moderate to high disease activity. In patients who are at increased risk of osteoporosis because they've had a long duration of lupus or because they've used corticosteroids for a long time, depo-progesterone acetate is not preferred as a long-term contraceptive because it leads to a BMD decline by up to 7.5%, which is very high compared to the efficacy rates of bisphosphonates, which we see in many trials, which range from 4 to 5%. There's a lot of green shoots in the use of medicines in patients with lupus during pregnancy. And most of us are well aware that uh, drugs like hydroxychloroquine, azathioprine, prednisolone, the cyclosporin tacrolimus, and most NSAIDs are safe in the intrapartum period and the lactation. However, this should be very clearly communicated to as many obstetricians and gynecologists who fall within our range of influence, because they are very, very scared of continuing these medicines, and so are the patients. So, the hydroxychloroquine and azathioprine are absolutely safe, while prednisolone, here the American College recommends that if you have a dose less than 20 milligram, there is no problem. But the EULAR recommendations say that up to 50 milligram, there is not an increased risk of either miscarriage or congenital malformations. The previous concept that cleft lip and cleft palate incidence is increased has been removed by many, many more pregnancy data which is available. When we use tacrolimus and cyclosporin, we generally focus on monitoring the blood pressure as well as the sugar levels. The NSAIDs impair implantation, so are not recommended in patients who are experiencing infertility, but they can be continued in the first and second trimesters, but avoid in the third trimester for the risk of patent ductus arteriosus. There is absolutely no indication to give methotrexate, eflunomide, MMF in patients who are planning or who are pregnant and during lactation. The only caveat is that cyclophosphamide, you might consider it in the second and third trimester if you are in the unfortunate situation of a patient with very active organ-threatening lupus who is also pregnant. The outcomes are not good, but as you wait for the outcome, you might have to use these drugs to save the mother. Mycophenolate embryopathy is very well documented and includes a characteristic uh, micro everywhere, which could be in the external auditory canals, it could be the fingers, there could be ocular abnormalities around the same lines, and hence even the EULAR, from all the published cases, there is almost a 30% incidence of congenital malformations when used in the first trimester, and so it is absolutely contraindicated. We often have to use antihypertensives in patients with lupus and those who have chronic kidney disease due to lupus nephritis. Labetalol, nifedipine, methyl-dopa are safe in pregnancy and lactation. However, there is a small concern that methyl-dopa may cause postnatal depression, and so you may consider a switch during that time. The ACE inhibitors and ARBs are safe to use in the first trimester, but they are fetotoxic in the second and third, and even during lactation, it is not advised to give ACE inhibitors and ARBs. Just a few words about cyclophosphamide because of our own recent experience with the need to give it to a woman who was 28 weeks pregnant. There is definitely a 30% incidence of congenital malformations when used in the first trimester, and the morphology is typical of small for gestational age with blepharophimosis, abnormal ears, flat nasal bridge, and a high arched palate. There have been numerous case reports in the last 3-4 decades describing congenital malformations. However, there are small green shoots which have reported successful pregnancy after cyclophosphamide therapy. But as you can see that miscarriages are also high, and often this is said that this is due to the underlying disease. So even in 80 patients of breast cancer who were exposed to cyclophosphamide, there were only 3 patients who had congenital abnormalities. So this is something we can keep in mind. Another very important area in lupus pregnancies is chronic kidney disease. We often have patients who have 5 to 10 years of lupus and have had successful remissions in lupus nephritis, but are stable at a creatinine of 1.4 to 1.8. So, what has been shown is that there is a very high risk of worsening and a high risk of progressing to end stage renal disease. And so I think this should be used when we counsel patients who want to decide whether it is worthwhile to take the physiological burden of pregnancy in along with their lupus. In 49 prospective pregnancies, where there was at least 1 gram proteinuria and a low GFR, there was a further decline by 1.2 ml per minute per month for the 6 months postpartum that these patients were observed. Now, preeclampsia, we all know, is a combination of new onset hypertension and proteinuria at more than 20 weeks of gestation. But sometimes preeclampsia comes only with hypertension, with evidence of another systemic disease like thrombocytopenia or transaminitis or renal insufficiency, and its consequences like pulmonary edema or a PRES. Sometimes preeclampsia can present only with hypertension and upper quadrant pain, and the HELP syndrome is considered to be a subset of preeclampsia. Now, why this is important is because it is very important to differentiate between what we think is a lupus flare and what is preeclampsia, because the treatment of the first does not involve termination of pregnancy, and the treatment of the second means that you have to decide that no, there is no more time, we need to terminate the pregnancy. It is most of the time not very difficult to differentiate the two, keeping in mind that hematuria is seen only in lupus flare, and that you will always, not always, but most often have a clinical lupus active elsewhere also. However, if it is unfortunate that you don't have any lupus elsewhere, you could still look at some biomarkers like low complements and increased dsDNA. But if this is not there, then there are actually very good studies which talk about the tyrosine kinase and the platelet growth factors as biomarkers for preeclampsia. This is especially relevant for gynecologists and obstetricians because they have a lot of patients, primaries who have preeclampsia, and they would want to know whether somebody with a familial preeclampsia will have preeclampsia or not. A very highly rated study in the NEGM published in 2006 involving a lot of patients in different scenarios of preterm eclampsia, term eclampsia, gestational hypertension, no hypertension with low birth weight infants, and no hypertension with normal weight infants showed that increasing ratio of the tyrosine kinase and the platelet growth factor heralded within the next 1 week the onset of preeclampsia. And this cutoff value of 38 had a negative predictive value of 99% for absence for occurrence of preeclampsia in the next 1 week. Now, there was a very nice study, PROMISE study, which also emphasized the same importance of these biomarkers. So, of all the studies that we have seen, combining them, it is very evident that thrombocytopenia and other features of lupus disease activity predict a poor fetal outcome, and studies from which involve patients as low as 385 and our own study from Karnataka, which includes 121 patients, suggest that presence of lupus anticoagulant, antihypertensive use, which means a hypertensive disorder in pregnancy, predicts an adverse pregnancy outcome as well as maternal outcome. The flare rates can be as high as 26% in the pregnancy, and major flares can be as high as 4%. In the antiphospholipid antibody syndrome, when we have only an obstetric APLA, then therapy recommendations include low dose aspirin and prophylactic low molecular weight heparin. There is recommendation against the use of IVIG, against the use of therapeutic doses of low molecular weight heparin, and prednisolone. So steroids are not indicated in obstetric APLA. In those who do not meet the criteria for obstetric APLA, have only antiphospholipid antibodies, also such therapy is not recommended. If the patient has had thrombotic Aplar syndrome and is currently pregnant, then the only difference is that you need to give therapeutic doses of low molecular weight heparin, which means twice the prophylactic dose. There's a very useful reference published recently in May 2020, which reviewed the following treatment options in patients with persistently positive antiphospholipid antibodies. They reviewed aspirin alone versus placebo, heparin plus aspirin versus aspirin, low molecular weight heparin versus aspirin, low molecular weight heparin plus aspirin versus unfractionated heparin and aspirin, and a higher dose of heparin plus aspirin versus low dose heparin and aspirin. And they looked at the outcomes, and the number of studies in these was the number of randomized control trials available for each of these treatments was ranging from 1 to 5. The outcomes which were reviewed were how many live births happened with each treatment, what was the frequency of preterm delivery, IUGR, pregnancy loss, preeclampsia, and what was the frequency of adverse events in the mother of the child. So if you look at the next few slides and you look at the small diamond at the bottom center of the slides, then the evidence for aspirin in improving preeclampsia, you see the effect size is very small. Evidence of aspirin for improving preterm birth is also very small. And the evidence for aspirin in improving intrauterine growth rates is also very small. So the overall benefit as mentioned in the Cochrane database for any of these outcomes for aspirin is labeled as very uncertain. For heparin plus aspirin, the overall evidence is that it may increase the live births that with a relative risk of 1.27 and a narrow confidence interval. It may also reduce pregnancy losses, but again, the effect size is very small, though the confidence interval is narrow. Then should it be low molecular weight heparin or unfractionated heparin plus aspirin for efficacy? Live birth rates with a large population of 1,000 women using low molecular weight heparin, the relative risk was 1.2. With unfractionated heparin, it was 1.74, which means that unfractionated heparin has an advantage. However, the data comes from 140 patients for unfractionated heparin. About oral anticoagulation in Naplus syndrome, it is not recommended by the Society of Thrombosis and Hemostasis because rivaroxaban in a meta-analysis showed increased thrombotic event rates compared to warfarin. The neonatal lupus syndrome characterized by cytopenia, rash, and transaminitis, which is reversible by itself, or a complete heart block, which is irreversible and occurs in 2% of those who have high titers of anti-Ro and anti-La antibodies. So all women with these significant antibody titers should receive hydroxychloroquine. And if there is no previous congenital heart block, a strict fetal surveillance between 16 to 28 weeks should occur. And if there's a previous CHB, it should be more frequent than once a week. Steroids are not indicated. Uh, in patients, though fertility is not an issue in lupus, infertility in the general population is high. And so some of these patients may require assisted reproduction therapy. They can all be given if they have stable or low lupus disease activity, if their APL status is negative. Conditionally, if their APL status is positive but no clinical features, you can treat them prophylactically with low molecular weight heparin. But if there has a past thrombotic APS, you should give therapeutic low molecular weight heparin during reproductive therapy, ART. Immunosuppressive therapy should be continued except cyclophosphamide, which affects the maturing follicles. In moderate or severe disease activity, do not do assisted reproduction therapy. So in conclusion, I would like to just take you through these important 3 notes. One is consider whether the patient has lupus or not, consider whether the patient has anti-Ro antibodies or not, and consider what is the status of the antiphospholipid antibodies. We might have to do more than once antiphospholipid antibody tests. We could use beta-2 GPI, we could use the LSE. It would be best if we do all 3. And if we don't find any antiphospholipid antibodies, a low dose aspirin is a conditional recommendation. If we find obstetric APS or thrombotic APS, then we have to treat with aspirin plus heparin. And there is no role for steroids in these patients with antiphospholipid antibody syndrome. Thank you for your kind attention.
Thank you, Dr. Rajshekhar. That was a very nice talk. And we have a few questions from the audience for you. Dr. Behara wants to know that ICMR says that HCQS is contraindicated in pregnant women with COVID-19, but the same is not true for patients who have rheumatic diseases, especially lupus. So why is that?
So I think the only reason why they are saying that is because the dose which they use in COVID for prophylaxis, as well as some of them who are recommending it for treatment of mild disease, is large. I mean, 800 milligram per day. Having said that, it is for such a short time that personally I would still say that I don't agree with the ICMR recommendation of contraindicating it in patients with lupus and COVID. We've had a lot of patients with COVID, and I'm sure the IRA registry will bring this up, who have
Yeah.
had COVID and recovered while being on hydroxychloroquine.
No, that he accepts, but what he wants to know is that if a patient who does not have a rheumatic disease,
Yes.
why is HCQS contraindicated in the pregnant women with COVID-19?
No, it is not contraindicated.
Okay, thank you. There is another question. If a pregnant woman is on, the conception was when the patient was on methotrexate, is abortion the only answer?
So, with most of these who are drugs which are absolutely contraindicated, the risk of malformation is around 30%. So, which means that you will still have a chance that you may have a morphologically normal fetus. But again, that depends on early detection of your anomalies. So, if you have a good center which can do good TIFA scans, then maybe you would be able to terminate the pregnancy at 16 weeks if you find fetal anomalies. So, that's how far I think you can take it with methotrexate.
Right. Dr. Kumar wants to know the choice of induction agent in proliferative lupus nephritis in pregnancy if the patient has already failed on cyclophosphamide and mycophenolate mofetil. Can we give rituximab?
It's like desperation. So, we had a situation like this, and we decided that tacrolimus would be a reasonable choice. The efficacy for rituximab in induction therapy in lupus nephritis, though we are all are getting very comfortable with rituximab in lupus, but I don't think we have proof that it is a great induction agent. Similarly for tacrolimus. So, but if you have a risk of say diabetes or hypertension already there, you could try it. But the situation anyway is pretty grim.
Yeah. The next question is, Dr. Sarkar and Dr. Tripathi want to know the sensitivity of uric acid measurement in differentiating lupus flare and preeclampsia, lupus nephritis and preeclampsia.
That's a tough question to answer because I have not read detailed studies about uric acid between these two, though there is suggestion that in preeclampsia the uric acid falls. But more and more, the current review articles which talk about differentiating these two do not talk about uric acid. So,
A couple of quick questions. How to treat pregnant lupus with high anti-Ro antibody with fetal arrhythmia? You did mention this.
yes. So
Yeah.
if you have a first and a second degree heart block, which is detectable on a fetal ECG and a fetal echo, then you might consider using steroids because sometimes these are reversible. These steroids are usually continued up to 32 weeks. But if you have a complete heart block, then using a pacemaker either in utero or as soon as the child is born, depending upon the degree of heart failure and the consequences of the low heart rate, is what we need to do.
Right. And yeah, one more question has come in. Any role of IVIG in neonatal lupus?
Uh, the neonatal lupus, which is like manifests as rash, cytopenias, and transaminitis, is quite often easily reversible even if you don't do anything. So there is no indication for IVIG there. For heart blocks, the early heart blocks, first and second degree, no indication. For congenital heart blocks, also no indication. But there is a study in patients who have had recurrent CHBs. They have tried in 8 to 10, if I'm not mistaken, patients. They have shown some benefit. But personally, this is such a small data and the cost is so high. It would be 10 to 12 lakhs because you'll have to give it every month for at least 4 to 5 months between 16 to 32 weeks.
would you prefer low dose aspirin or full dose aspirin in obstetric apla?
Low dose aspirin is defined by aspirin up to 150 milligram per day, and high doses above that. Most of the studies talk only about 150 milligram.
Right. And the last question that we'll take is, in a patient with lupus who wants to terminate pregnancy in the first trimester, what is the preferred mode of termination, DNC or medical termination?
Mm, I will not be the best person to say this, but I think medical termination is safe. Use
Okay,
of prostaglandins in lupus is safe.
okay, right. The questions are still coming in. Uh, your drug of choice, the final one, in organ-threatening lupus flare, cyclo-resistant, is it weekly IVIG?
IVIG might work in it works in the hematological manifestations the best, and probably in the CNS, where if you have a myelitis, you will be looking at giving IVIG. For the rest of it, it is very unproven data of whether it will
Okay.
really help.
Yeah. Thank you, Dr. Lisa. We have not been able to take all the questions.
Thank you.
Uh, thank you for an excellent presentation. Rohini, you can take over.
So thanks, Lisa. That was an excellent talk. And I have the privilege of introducing Dr. Ramnath Mishra for the next talk. And he is the last person who actually needs introduction to this audience. But this is part of our protocol. And so after a very illustrious career at Sanjay Gandhi Postgraduate Institute of Medical Science, Dr. Ramnath Mishra is currently working as professor and head Department of Clinical Immunology and Rheumatology at Kalinga Institute of Medical Sciences. At the SGPGI, as we all know, he spent a long 30 years, and he was instrumental in establishing the clinical division of the department, which has trained a large number of DM students in clinical immunology. He did a short stint at UK at the Kennedy Institute of Rheumatology with Sir Professor R.N. Maini, which must have been a great experience. He's also a fellow of the Indian Academy of Medical Sciences, Royal College of Physicians of London, and has been awarded the prestigious M.N. Parsi Award for Lifetime Achievement by the IRA and the S.R. Naik Award for Outstanding Research Contribution by SGPGIMS. His areas of research are SLE, reactive arthritis, and vasculitis. He has 225 publications with over 4,000 citations and an H index of 33, which is really huge. He will be speaking on a topic which is very close to all rheumatologists' heart. So we want a steroid without side effects, or if not, we at least want to use the very lowest possible dose or no steroids. So his topic for today is, should we be using lesser corticosteroids in lupus? An evidence-based argument. So over to you, Dr. Mishra.
Thank you, Rohini. Thank you, Rohini, for that nice little introduction, mostly written by me. So it was all flattering one own self. I thought you could add one or two, but never mind. We would start with the presentation. I'm thankful to Alakendu, Sapan, Sinoy, whoever have invited me to talk on this topic. It's actually a debate topic. It would have been nice if one tells that we use conventional dose of steroid and the other one stand up to say that we use lesser dose of steroid. Actually, I would have preferred to use the conventional dose of steroid myself. So it's somewhat challenging for me to provide evidence to use less and less of steroid in managing lupus. I would be talking mostly about lupus nephritis because that is the category of lupus where a lot of questions arises. We tend to use a large dose of steroid at the induction and then maintain steroid. And therefore these questions have come: how much, how little, and how long. this would not cover other organ involvement of SLE. That steroid is beneficial, continues to remain beneficial. There are any number of studies, and this is one such very early studies saying that, suggesting that methylprednisolone in pulse doses helped in 7 patients with DPGN. 5 of them reversed their abnormal parameters within a month. Till that point of time, we never had such kind of agent, pharmacological agent, to act so quickly and to act so completely. So over the last, since 1964 actually, we have had several landmark trials to suggest that we have gone over, we have known, everyone of us know that the NIH trial, the trial with steroid versus cyclophosphamide versus steroid, the introduction of MMF steroid with cyclophosphamide steroid, then the famous Lupus trial, the ARMS trial. All these trials did suggest that the additional immunosuppressive drugs such as cyclophosphamide or mycophenolate is superior to steroid. But one thing is very important: all forms of nephritis, I mean, mostly they were talking about proliferative lupus nephritis, had steroid in them. Even the cyclophosphamide arm, the mycophenolate arm had steroid in there. So steroid is the cornerstone, and it did have add-on value, or the cyclophosphamide or MMF had add-on value to steroid. And you can see one of these studies that suggested that methylprednisolone with cyclophosphamide performed better in terms of renal remission as compared to cyclophosphamide or methylprednisolone alone. We remember the NIH trial where those patients who were on steroid alone, they did not do as well as those who were on cyclophosphamide or even azathioprine. But we cannot deny the fact that steroid is the cornerstone of therapy. So almost all of us who are involved with care of patients with lupus, particularly nephritis, cannot do away with steroid, clearly knowing that in the induction stage or in the acute stage when the patient presents to us, it is steroid which rapidly reverses the inflammatory phase in the kidney, and to the extent whenever we even taper the dose of steroid, we do so slowly and maintain for an indefinite period. But there are many questions which are unanswered. Why? As for the pharmacological mechanism of action, steroid dosing has been divided into 4 types. Low dose up to 7.5 milligram per day, medium dose up to 30 milligram per day, a higher dose 30 milligram or above. That is what we usually start with induction treatment, like 1 milligram per kilogram, and pulse dose generally is given either 250 milligram or 500 milligram, or sometime even 15 milligram per kilogram of body weight, very high dose. So it is this cohort from Dr. Michel Petri group that for the first time suggested that long-term use of steroid or chronic use of steroid is associated with significant damage in SLE. But it was not steroid alone. It was many other factors were involved, such as those who had more disease activity, those who were elderly, those who had low complement activity and more extensive disease. I mean, you would argue that it is only in this category of patients that we give steroids. So to find out exactly what is steroid contribution is difficult. And we have an Italian study which almost mirrored that effect, that use of glucocorticoid is statistically significantly associated with presence of chronic damage. But as you can see in this slide, it is the disease duration and the number of flares and age also contribute to damage. So it is persistent inflammation and of course the use of steroid, which goes hand in hand. But these studies do suggest that can we do better by using less of steroid so that the damage is less. And what is the damage? The rate of adverse effect of medium to high dose glucocorticoid is computed from 8 randomized controlled trials, that it is about 9 per 100 patients every year, 25 per 100% per year for infection, and 12 for avascular necrosis. So it is quite high. And even the data from this system reviews suggest that an increase of 1 milligram per day of methylprednisolone is associated with 2.8% increase in the risk of organ damage progression, which sounds quite bad. So should we be using lesser steroid in lupus? Certainly yes, but the concern is, are we not allowing ourselves to have an increased risk of flare and consequently more organ damage? Tried rather bravely to use less dose of steroid or no dose of steroid. And what was the result? This is a study from a combination of Spain, I mean, 2 centers, 2 university of Spain, which say that it's a crucial study, which used for induction of biopsy-proven class 3 or class 4 nephritis, methylprednisolone 250 to 500 for 3 days, with a starting dose of steroid 20 to 30 milligram instead of 1 milligram per kilogram of body weight, and given cyclophosphamide fortnightly, like we do in urolupus, not for 6, but maybe for 9 or 12 doses, depending on clinical outcome. And those who had class 2 nephritis, only 15 milligram. And for class 5, only 15 milligram of prednisolone along with mycophenolate. And the maintenance dose was between 2.5 to 5 with addition of cytotoxic drugs like Adaran or mycophenolate. And the tapering schedule. We all know that there is no accepted tapering schedule, and different clinicians manage tapering according to their own schedule. And they, in fact, they did it rather boldly. For class 3 and 4 patients, 30 milligram 2 weeks, then 20 milligram 2 weeks, then 15 milligram 2 weeks, and 10 milligram 4 weeks, 7.5 milligram 4 weeks. So in fact, by 10 weeks, the steroid dose was down to 5. And these were 15 patients with lupus nephritis, and they compared with their historical cohort. This study show that, those who had on the CPC protocol, they had initial dose of steroid, the median was 20 as compared to 50 of the historic control. Historic cohort had 30 patients. And all these cumulative prednisolone dose was less, 1.65 to 4.2. And weeks to prednisolone is 5. Here you note the difference, 16 weeks. By 4 months, it was down to 5. And here in the traditional way, it took 87 weeks. And of course, methylprednisolone was used here, 1.5 gram. And cyclophosphamide dose was 3 gram versus 5 gram. And number of patients who received hydroxychloroquine was 15 here and 10. And what was the result? One would have expected, because they have used less dose of steroid, that the remission rate would be less as compared to the conventional historic control. Surprisingly, 90% of their patients achieved complete remission. And as compared over a period of 300 weeks, only 65% of patients achieved complete remission. The real life figure, we all know it's about 65 to 70%. And the corticosteroid associated toxicity, only 10% have it in those who were on this reduced dose of steroid, whereas those with those who were on conventional dose, almost 60% had the toxicity. Can cyclophosphamide be given without steroid for renal lupus? This is a study where 40 patients with lupus nephritis received the NIH regime, which is monthly, and prednisolone was only given for extra renal manifestation. And they did a post hoc analysis wherein they categorized the patients who had received less of prednisolone, less than 20 milligram, to those who had received more than 20 milligram. None of the patients had actually received steroid for lupus nephritis. And then when they compare the difference between the two, the renal flare in the low prednisolone group was not statistically different than as compared to the high prednisolone group. This was a German study, and it did suggest that one can possibly manage lupus nephritis without steroid. But these patients were taking steroid for extra renal cause, and it could have influenced the results. But if we compare between the high dose and low dose, there was no difference. And then we have the rituximab study, which was rituximab followed by mycophenolate with no oral steroid, and 50 consecutive patients from Hammersmith Hospital. Consecutive patients with biopsy-preventive PGN, they were treated with 2 doses of rituximab, 1 gram, and methylprednisolone on day 1 and 15, with maintenance treatment of mycophenolate mofetil. However, patients who were on steroid, those who had more worsening disease and requiring dialysis, they were excluded. But one can see that even without use of steroid, at the end of 52 weeks, the serum creatinine has improved and the urine protein to creatinine ratio has improved. And even patients, 70% of them had achieved complete remission by between, say, 120 weeks. And then a good number of patients achieved complete remission and also partial remission. They had the follow-up data of 7 years, and the relapse rate was about 30%. So, and the limitation of the study was that severe cases were excluded and we do not have a control group. And currently there's a move to fast steroid tapering. We have this AURA trial of voclosporin, which tapered steroid down to 2.5 milligram by 16 weeks. And the starting dose of 20 to 25. And you see all these randomized control that the tempo has been to reduce steroid by the end of almost 4 months to down to 10 milligram daily. Of course, some of the results of some of these studies have not yet come. The voclosporin study results have come out, and the results, majority of patients achieved the primary endpoint. So these are indirect evidence that global trials or trials wherever conducted now with biologic agent, they have a tendency to start with a starting dose of 0.5 with a rapid tapering schedule. And the million-dollar question is when to stop steroid. We don't know the answer because there is no randomized control study either on how to taper or when to stop. These are small studies on 15 patients with lupus nephritis with partial or complete remission. We are randomized to take 7.5 or no steroid for maintenance. In fact, those who were maintained on steroid had more renal flare and all flare as compared to those who were not on prednisolone. The numbers of patients were small in each group, so we cannot compute the hazard ratio, the right kind of statistical analysis. This is another study. Again, this is a randomized controlled trial. 12 months patients were clinically in remission. They were either given 5 milligram steroid or no steroid. 61 of them were given 5 milligram and 63 had received no steroid. Those who were not given steroid, they end up having more relapse, and this was statistically significant. So the evidence that we have for mild disease, we don't need any MP pulse. The starting prednisolone can be max 20, and the tapering scheme can be 5 milligram every week, and the maintenance can be 5 milligram. For those with moderate to severe moderate disease, we can consider 1 to 2 pulses. Giving pulses actually help in starting with a low dose of steroid, something like 0.5 milligram, and we can taper as they did in the Spanish cohort to down to by 4 months, one active 5 milligram or even 2.5 milligram, 2.5 milligram. Those with more severe disease, of course, we give pulse. We could start with 0.6 milligram, and then once remission is achieved, 5 milligram can be tapered every 2 weeks till it is down to 20 milligram, and then 2.5 milligram every 15 days thereafter. Ideally, the dose should be 7.5 or lower. Somehow I prefer 7.5. I may be wrong, but people could come down further. So I would conclude that steroids are a necessary part of lupus management. Damage is associated with steroid. How much we don't know. There is a need to minimize steroid, and we do not have a randomized controlled trial-based evidence to suggest how to reduce the dose of steroid or when to stop steroid. But avoid steroid, use rapid tapering, maintain a low dose indefinitely. We still have many questions, still remain. Thank you.
I think that was quite lucid and very clear in your concepts, Dr. Mishra, as usual. And you did show promise that there is a possibility of lowering steroids in lupus nephritis. However, how to lower it, how fast to lower it, we still are in the process of finding out what is the exact way to do that. I had one question which bothers me always, and then we'll go to the questions on the panel. That is when we when we are stopping steroids in a patient who has been on long-term steroids, are we also, is there a problem of HPA axis suppression and therefore the patient lands up in trouble? Is that also a problem sometimes?
Oh yeah,
Do
yeah,
you
it
feel
is.
that way? Yeah.
Yeah,
So,
it is very
maybe
correct.
that is one of the reasons why we see a flare the moment, you know, that 5 milligram dose goes away. So
Right, right. It could be. It's a very possible biological explanation. I have done and usually recommend a ACTH stimulation test to find out the adrenal reserve before actually stopping the steroid. And many patients who stop steroid do start complaining about malaise, fatigue, increased fatigue, um, much before the real flare, renal flare or all flare occurs. Yes, it is possibly a good explanation.
thank you, Doctor. There are a lot of questions from the panel, from the audience. And this is from Dr. Kunal Chandwar. What is your choice of dose for pulse methylprednisolone, 1,500 or 250? And you start at 1 milligram per kg or 0.5 milligram per kg after the pulse. So he wants to know what is your choice.
Well, my choice is usually 10 to 15 milligram per kilogram of body weight, unless the patient is showing signs of rapidly declining creatinine function, when I could go up to 20 milligram per kilogram of body weight, and that is every day for 3 consecutive days. But it is just a personal choice, but many trials which have used biologic now, they tend to prefer use 500 milligram a day for 3 consecutive days if they have excluded patients with rapidly progressing renal deterioration.
Right. The other questions are, which is the glucocorticoid of your choice, prednisolone, methylprednisolone, and does maintaining the patient on long-term low-dose steroids, is it harmful? I think you have answered that in the talk. And so which is your preferred glucocorticoid?
My preferred
Methylprednisolone?
glucocorticoid, no, my preferred prednisolone is just prednisolone,
Prednisolone, right.
not methyl or dexamethasone.
And would a combination of rituximab with cyclophosphamide, as in vasculitis, allow lower doses of steroids? This is again from Dr. Kunal Chandwar.
Well, if you give rituximab, you can start with a low dose of steroid. You don't need the cyclophosphamide in it. The combination of rituximab with cyclophosphamide has been more accepted in ANCA-associated vasculitis, not for lupus nephritis. Yes, possibly if you're using rituximab and giving methylpred bolus, it's not rituximab, because you are using methylpred bolus, a larger dose of steroid, you could possibly start with 0.5 milligram.
Right. And I had a last question. Do you think that for non-renal lupus, we actually need more steroids than for renal lupus, looking at the data? Because most patients with lupus nephritis seem to have done better with lower doses, while for some hematological, and we do need to use steroids, and no other drug can actually substitute for the steroid.
Yeah, you are correct. If we have a cutaneous flare, we don't have a drug as good as steroid to have a dramatic effect. If it is a hematological manifestation like severe leukopenic, thrombocytopenic, or we have to use steroid. and maintain the steroid, the scenario is actually requiring more steroid rather than in nephritis. But there is another concern about me seeing patients who are managed widely of lupus, and this is a very serious concern. A lot of patients with lupus, they don't require steroid and they are given steroid. And
Right.
this is a concern for, there are certain, like someone with a skin and joint disease, you don't need steroid. You could well manage without steroid. Even that opportunity or that trial, that is not given, and steroid is given to them. That is a real worry.
I think there are lots of some more interesting questions, but we'll have to wind up now because the clock is ticking. And thank you, Dr. Mishra, again. I think these are important questions which Dr. Karke, Dr. Ashok Kumar have raised. And we'll probably, as Sapan said yesterday, probably discuss them on another forum. Thank you so much, Dr. Mishra. Over to you, Namisha.
Yeah, thanks, Rohini. Our next speaker is Dr. Ranjan Gupta. He's assistant professor in the Department of Rheumatology at All India Institute of Medical Sciences, New Delhi. His main interests are lupus and lupus nephritis. He is the recipient of national awards and research grants nationally and internationally. He is today going to talk to us on refractory lupus beyond tacrolimus and rituximab. Over to you, Dr. Ranjan.
Thank you, ma'am, and thank you, IRA team, for giving me this opportunity to speak on the topic. So I'm going to talk to you about refractory lupus and how do we treat it when we don't have to use rituximab or tacrolimus. So basically when we have failed on these two drugs. So I have nothing to disclose. And first of all, I would like to define what is refractory lupus. So the definition for refractory lupus has evolved over time. So initially the definitions were very vague, in the sense there was refractoriness or no response to standard treatment, or maybe high dose steroids or any immunosuppressants. But over time, people have tried to define, when they have added that in the definition, that there should be at least one immunosuppressive or at least two immunosuppressive drugs that would have failed. Further, there were improvements where they have added either cyclophosphamide or MMF. And recently, the definitions which have come up, they say that at least 6 months duration should be there for this response to have worked. So overall, the definition which has now recently that has come up, it says that to define anything as refractory, there should be at least 3 parameters. Number one, the parameter that you are going to assess in your response. Number one, the drug that you want the patient to be exposed to. And the number 3 thing is for how long do you want the patient to be exposed to that particular drug. So based on that, the consensus definition by EULAR, ERA-EDTA is that patient should have failed to improve in the initial 3 to 4 months, or patient would not have achieved, patient had not achieved partial response at 6 to 12 months, or maybe by 1 year, and no complete response after 2 years. Having said that, I would like to say that this is regarding lupus nephritis, and we are going to talk about refractory lupus in general. So there'll be a lot of overlaps about refractory nephritis, refractory lupus nephritis versus refractory lupus, and we'll have to go with that, because there are no definite definitions for refractory skin lupus or say refractory lupus in other organs. Now, refractory lupus nephritis, why it cannot be diagnosed with biopsy, which is otherwise the gold standard in lupus nephritis diagnosis. So with this slide, I would like to reiterate the facts that Dr. Abraham has told yesterday, that if we see this, the patient who had clinical complete response at the end of induction phase, and if we do a renal biopsy, almost 1/3 will show a histological non-response. Similarly, if we see patients who have got a histological response on a biopsy in the end of induction phase, more than 50% will not have achieved complete response. So this is the limitation of biopsy, and that is why biopsy is not the answer. Now, what are the general principles behind any kind of refractory lupus, be it in the skin, be it in the kidneys or anywhere else? So first of all, we need to rule out other possible factors that would lead to refractoriness. So number one is non-compliance, which could either be because of financial reasons, as may happen in India, or maybe it could be because of the intolerable side effects. The other thing in case of lupus nephritis is to rule out damage, so that we do not over immunosuppress the patient. And then doing a biopsy may be important, because we may find something which is completely unexpected, like thrombotic microangiopathy. The first principle is, if patient has had cyclo, give him MMF, or change vice versa, followed by a multi-targeted therapy, which includes steroids, mycophenolate, and tacrolimus, and then rituximab can be tried. But my goal for today's next 15 minutes is to discuss other options, which excludes all these things. So this is the slide, and there are 47 drugs on this, which are supposed to be the topic for today's talk of mine. And if you just miss the tacrolimus at the end, rituximab has not been mentioned, and I'm supposed to talk about all these things over the next 15 minutes, which is actually not possible. So let's divide them into some group. So these group of drugs that you're seeing are actually B cell depleting drugs. So either they work on the B cells itself, on the surface markers, and kill the cells, or they attack the trophic factors for B cells like BAFF and APRIL. The other group of drugs are these drugs which work on the cytokines in the milieu, and then try to bring down the pathophysiology, attack the pathophysiology itself of lupus nephritis. Then we have drugs which can work on the intracellular signaling mechanism, like proteasome inhibitors, or we may be having BTK inhibitors or calcineurin inhibitors. And then the last group of drugs are the ones which are involved in the stimulation of the cells. However, out of all these things, out of all these drugs, the drugs which are commonly in vogue and in trials are these, and I'm going to talk about these things. So targeting B cells could be either again B cell depletion, or targeting the B cell cytokines, or intracellular mechanisms like proteasome inhibitors. We may discuss about cytokines, interferons, and their receptors. And lastly, I would like to discuss about the bone marrow transplant and some miscellaneous drugs that may be useful. So among the B cell, when we speak about targeting the B cells, so it could be either targeting the B cell numbers by attacking CD20 or CD22, or it could be targeting the B cell cytokines, which is BAFF and APRIL, or it could be the proteasome inhibitors. Now, straight away, I'll come to belimumab. The two old trials, BLISS 52 and 76, which were phase 3 trials, included almost 1,500 patients. There were 3 arms. These are placebo-controlled trial, but these 2 trials did not include severe lupus like lupus nephritis or NPSLE. And they also excluded patients who had earlier received rituximab. Primary response was SRI-4 response, and both of them favored the use of belimumab, as is seen by these two forest plots on a meta-analysis of these 2 trials, where we can see that use of belimumab is favored by both the trials, more so by the BLISS 52, which is black box, and BLISS 76, which is a white box. Now, BLISS 76 was not as, the results were not as good as BLISS 52. Then the reason was that the population that was enrolled in these 2 trials was quite heterogeneous. So BLISS 76 enrolled people more from the Native American and Asian population, which are known to have slightly resistant disease as compared to other population like Caucasians. So it was concluded that belimumab is more likely to benefit those patients who have high disease activity, have concomitant steroid, taking concomitant steroid, they are seropositive and have low complements. Now, recently, last month, a trial that has been published in NEJM, which is testing the use of belimumab in refractory lupus nephritis. So it was a double-blind randomized placebo-controlled trial, taking almost 450 patients distributed in 1:1 arm, where background immunosuppression was allowed. And if we see the definition here of refractoriness, so see, they have excluded only those patients who have not failed to, they have included those patients who have failed either to cyclophosphamide or MMF. So patients who have failed to both these drugs were not included. So in that way, they have actually not taken refractory lupus nephritis cases. They have also, their primary endpoint was a novel endpoint, which was primary efficacy renal response at 2 years endpoint, 2 years, which meant UPCR of less than 0.7, no decrease in EGFR, and no rescue therapy used by the patients. And if we see the results, the belimumab was successful at the end of 2 years in achieving its primary response, and in patients who achieved a complete response. Also, a possibility of renal event or death, which meant death or increase in creatinine or increase in proteinuria, was also low in belimumab. So this way, this trial was quite successful in achieving its primary endpoint as well as most of its secondary endpoint. And this shows that when given with background immunosuppression, belimumab can be successful in treating patients who have lupus nephritis. Now, a recent concept that has come up is the measurement of BAFF levels in patients who have been treated with rituximab. So people saw that once they are given rituximab, at the end of 3 months, when the B cell counts are least, BAFF levels are at their peak. And at 6 months, when the B cell repopulation happens, BAFF levels come down. So it was thought that probably BAFF was responsible for B cell repopulation. And the concept that emerged was to use sequentially, first give rituximab and then give belimumab to mop up all the BAFF and not let B cells repopularize. And this worked. In this small study, you can see that after giving sequential belimumab, the change in B cells the B cells remained low throughout, and the BAFF levels also decreased throughout the period, even at the end of 6 months. And the trial which has followed this strategy is the Calibrate trial, which has come up in this year. It is a small trial which is actually phase 2 study, just to study the efficacy and safety, not to study the efficacy, but to study the efficacy and the safety. It has only 43 patients, and they had active disease despite being treated on MMF on cyclophosphamide, which means true refractoriness. These patients have been given rituximab, cyclophosphamide at 0 and 2 weeks, along with methylpred bolus. Hydroxychloroquine and prednisolone was continued. They were randomized into 2 arms, either receiving placebo or receiving belimumab IV. At the end of 96 weeks, there were only 14 patients left in both the arms, 7 each. And so efficacy analysis could not be done. However, the drug was safe. There were no adverse events which was significant. And the basic part of it, that was about the B cell numbers, it was shown that the end of 60 weeks, that means once the 6 months period is over, in patients who received belimumab along with the other 2 drugs, B cells remained persistently low. Naive B cells were significantly decreased. Now, in other smaller studies, it has been seen that once used sequentially, belimumab after giving rituximab, it has significant clinical response. Like this small study, which is a single-arm open-label study with 13 patients with lupus nephritis, proteinuria decreased significantly over time, over 6 months. Here, there was no background immunosuppression was allowed. So belimumab, when given along with rituximab, could be sufficient in itself. Now, another concept that we come across in rheumatoid arthritis when we want to switch the class of biological drugs. So the question comes whether we should use another drug in the same class when we use TNF when there is failure, or we should switch to another completely different class like rituximab. So the same concept has been seen in lupus also, where 14 patients with secondary non-depletion, non-response were tried. Belimumab in one arm versus non-belimumab group of drugs, which were again B-cell depleting therapies. So after giving rituximab, which is a chimeric drug, the concept was that probably they developed Haka, and that is why the secondary failure happens. So either they should be given either a human or humanized antibody to deplete B cells further, or they should be tried on belimumab. And in this study, so secondary non-response was defined that either the patient has infusion reaction or failure to deplete B cells. Surprisingly, it was seen that patients who received belimumab after rituximab did not do as well as compared to patients who received another B-cell depleting therapy. The SLEDAI, BILAG scores, prednisolone dose all came down in better way as compared to belimumab. So based on these results, another large trial of almost 200 lupus patients, Bliss Believe, is in underway, and the results may be out by next year, June, where they're going to try belimumab in succession with rituximab to see whether it can be effective, it can be more effective. However, this trial again does not include lupus nephritis and patients with NPSLE. Now, continuing on BAFF inhibition, we have another drug which is blisibimod, and it has been tried in phase 3 double-blind randomized trial where adult patients with active disease of SLEDAI more than 10 were enrolled. Concomitant steroids and immunosuppressive agents all were allowed. However, again, this trial did not include patients with CNS lupus and lupus nephritis or vasculitis, that is severe disease. Primary endpoint was SRI-6 at 52 weeks, 1 year, and this trial showed a decrease in biomarkers like anti-DSNA, normalization of complement levels, but it did not achieve its primary endpoint of SRI-6. And it was thought that probably high dose of steroids in the controls was responsible for this. Another drug, tabalumab, which is again a BAFF inhibitor in Illuminate-2 trial, almost the similar kind of profile, a phase 3 trial, moderate to severe lupus, does not include very severe lupus cases like CNS lupus, lupus nephritis, and vasculitis, having SRI-5 at 52 weeks. And this trial did achieve its primary endpoint, but it failed to achieve 3 important secondary endpoints, which were reduction in steroid dose and change in fatigue index. They were also seen, the depression and suicidal ideation was also seen in the patients, and that is why this drug is probably going to go out of vogue, and the company has decided not to develop it further. We go to completely different class, which is anifrolumab, which is an interferon inhibitor. It is again a large trial that has come up in NEJM this year, and it was a randomized double-blind phase 3 trial taking patients with active disease despite on steroids and immunosuppressants who had at least SLEDAI of more than 5, a bilag which is at least in one organ A class. Background immunosuppression was stable and continued throughout this trial, and this trial again does not include patients who had lupus nephritis or neuropsychiatric lupus. Primary endpoint was a different endpoint. This time it was called BICLA, which is slightly more stringent as compared to SLE responder index, because it among all the apart from all those criteria, it also includes that there should be no discontinuation of the trial intervention and there should be no use of the restricted drug protocol. And it was seen that with the use of anifrolumab, BICLA response was achieved in patients. Time to flare was more in cases of anifrolumab, and this trial again achieved most of its primary and secondary endpoints. Yes, the herpes zoster rate was higher in patients who were in the treatment arm. Bortezomib trial, which was bortezomib is a proteasome inhibitor, and yesterday Dr. Chengappa had discussed this. It was there are not larger trial but small series in less number of patients, like 12 patients this trial, where they were refractory to cyclophosphamide, mycophenolate, and rituximab. They were treated with IV or subcutaneous bortezomib with steroids, and all background immunosuppression was stopped. I'm sorry, there's a problem with the animation here. So there was response. Patients had improved on their proteinuria, but the major problem was hypogammaglobulinemia, which happened in all the patients. However, nobody developed a serious infection. Now, the drug which is coming in vogue in many diseases, and probably it may be the answer to refractory lupus in near future, which is low-dose recombinant human IL-2. A small study published with 40 patients with refractory disease, where 1 million international units were given for every other day for 2 weeks with a break of 2 weeks. Again, it does not include patients with NPSLE, but there were patients who had nephritis. Primary endpoint was SRI-4. And we can see that it led to reconstitution or increase in number of T regulatory cells, which is the mechanism by which it acts. Patients had a good response, SLEDAI decrease, leukopenia improved, platelet counts also improved. There were no serious adverse effects. There were only 2 dropouts. And in a group of patients of almost 13 patients, proteinuria also decreased from more than 2.2 grams to less than 1 gram. So it seems that it could be effective. And again, a larger trial which was published this year on 60 patients with 1:1 distribution in a treatment and a placebo arm. Background immunosuppression was again continued along with the same regimen of IL-2. However, this trial does not include patients who had neuropsychiatric lupus. On completion of the trial at 6 months, SRI-4 response was better in the treatment arm. SLEDAI was lower in treatment arm. Steroid sparing was seen, and patients were more likely to reach complete response in treatment arm. Again, this trial had a few patients who had nephritis, and in them the renal response was also good. This trial also showed that low dose IL-2 not only reconstitutes T regulatory cells to higher number, but it also increases the number of CD56 bright NK cells, which again have regulatory property. So baricitinib was recently tried in a larger trial in almost 300 patients, but the patients did not have lupus nephritis or NPSLE, and the response was encouraging that it improved patients' rash and nephritis. Iguratimod is another drug which has been recently tried again in smaller number of patients. These patients did have proteinuria, which again improved with at the end of the trial. And the trial was very small and did not have much significance. It may be coming up in a near future. Again, hematopoietic stem cell transplantation has been tried in almost 22 patients in a trial, and the results did show that patients who had proteinuria, there was improvement with very low treatment-related mortality of only 5%. However, it was not a prospective trial, and probably a larger trial will be needed. So basically, we are dealing with the disease, which is again in itself is undefined, and there is no magical drug so far. But as far as refractory non-renal disease is considered, probably B-cell depleting therapy from a different class of drugs or a sequential belimumab may be useful. And for active renal disease, so far the results which are encouraging are only for belimumab. Thank you.
Thank you, Dr. Ranjan. We'll take a couple of questions which have come about, and then we'll hand it over to Professor Rahman. What about thalidomide and leflunomide from Dr. Amita Agarwal?
So thalidomide and leflunomide has been tried. Thalidomide recently there are trials, but there are again small trials I've not covered in my talk, but yes, there are a few trials on that, but the results are not very good. Not as good as what I've discussed.
Dr. Kunal also is asking you about leflunomide has shown some efficacy in Chinese studies. What are your comments?
Yeah, so there are some studies. Even earlier also there have been trials. These may be some newer trials. There have been earlier trials on leflunomide, but the results are not as encouraging, and probably it may not be the drug which may be used in nephritis in the near future.
Why particularly low dose IL-2 was tried in lupus nephritis from Dr. Balakrishnan?
So again, the mechanism is same. So IL-2 is a very important trophic factor for all T cells, but when given in larger doses, actually it is taken up by pro-inflammatory T cell components like Th1 and Th17. So that is why, and once it is given in lower doses, so CD25, which is its receptor, is present in more abundance on T regulatory cells, and that is why the increase in number of T regulatory cells is more as compared to pro-inflammatory cells.
Thank you. Thank you, Dr. Ranjan. We'll have to close this session. Rohini, you can take over. The unanswered questions we will try and accommodate by answering via email.
Thanks, Namisha. It's my privilege and honor to introduce our international guest, Professor Anisur Rahman. He has qualified from Oxford in 1988, and he trained in rheumatology in London, obtained a PhD for research into the molecular properties of autoantibodies that cause tissue damage in lupus and antiphospholipid antibody syndrome. He began to build his own research group in 2000 when he was appointed senior lecturer at University College London. He was awarded the Michael Mason Prize for this research at the British Society of Rheumatology in 2004, and then promoted to a personal chair in rheumatology in 2008. In addition to this basic science work, Professor Rahman has developed a clinical research program in autoimmune rheumatic disease and chronic pain. As a member of the BILAG and SLIC groups, he is involved in large multi-center projects in the field of lupus. His basic science group is developing a potential new therapeutic agent for antiphospholipid syndrome. So I invite Professor Rahman to share his thoughts, his experiences on the topic for the day, antiphospholipid syndrome, diagnosis and management, what is new? Welcome, Dr. Rahman.
Hello to everybody. It's a great pleasure to be invited to address this meeting in India. It's the middle of the afternoon here in London, a very grey day. and I've been asked to talk about the antiphospholipid syndrome. So, the antiphospholipid syndrome, these are my disclosures before I begin. So these are the questions I'm going to try and address during this talk. What is this syndrome? How do you prevent recurrent thrombosis in a patient with this syndrome? How do you manage pregnancy in a patient with confirmed APS? How do you manage people who have the antibodies, but they don't have the syndrome yet, the asymptomatic carriers of the antibodies, either for preventing thrombosis or to make their pregnancies go all right? And I'm going to deal with the rather controversial question of, is there such a thing as seronegative APS? And the way I'm going to be doing this is I'm going to talk through some imaginary patients, patients which I have made up the cases, just to see how you might address those problems. And during the talk, I'm going to be referring to these new guidelines, which were published by the European League Against Rheumatism. This was last year. This is the reference at the bottom. These are very good guidelines, I think. They're up to date with the evidence. And wherever you see me refer to these guidelines, you will see this green color, similar to the green of the Indian flag by coincidence. What is antiphospholipid syndrome? It is the commonest acquired cause of thrombophilia, people getting recurrent thrombosis, but they weren't born that way. So it's an acquired cause. In the past, it caused 10 to 20% of recurrent miscarriages. So about 20, 25 years ago, people were having 4, 5, even 6 miscarriages due to this syndrome. This is not the case now because treatment is better. You must think about this syndrome in people who are young and have thrombotic strokes. So it caused up to 1/3 of strokes in under 50s, at least in countries like Holland and the United Kingdom. APS can be primary. That means you've got APS and no other disease with it. It's by itself. Or it can be secondary when it occurs in the context of another disease, most commonly lupus. And we know that the disease is caused by antiphospholipid antibodies, antibodies which are created in the body and which cause this damage. There's lots of evidence of that. Although I should say that the term antiphospholipid is itself a little misleading, because now we know that these antibodies don't bind directly to phospholipid molecules. They bind to proteins that are attached to phospholipid molecules, of which the most important is beta-2 glycoprotein 1. But beware this test, because you can have healthy adults who are positive for it. There can be false positive tests for antiphospholipid antibodies. About 5% of healthy adults who have no syndrome at all might test positive. So that's a tricky thing. Now, it's not just thrombosis and miscarriage that people get in this syndrome. There are other features such as livedo reticularis, the classic lace-like rash on the thighs, and cardiac valve lesions, amongst others. But it's mainly thrombosis and miscarriage we're looking at. So, the important things I'd like you to take away from my talk today. Firstly, the treatment of this syndrome is essentially preventive. When we're treating a person with antiphospholipid syndrome, we are trying to prevent something from happening, to prevent a thrombosis, to prevent a miscarriage. We're not treating their symptoms. So some of these people may have no symptoms at all, and yet we're telling them to go into long-term treatment with anticoagulation, long-term treatment of asymptomatic people. So if you're going to do that, you have to balance the risk of what you're afraid of against the risk of side effects. The risk of a thrombosis or miscarriage has to be high enough that it's worth treating the patient. These are the classification criteria for APS, the definition of APS. Now, this has changed over the years since it was first described by Graham Hughes in the early 80s. And these are the most recent criteria, which are actually being updated now, but they haven't published the update yet. And it's very simple, actually. To diagnose somebody with APS according to this criteria, they must have at least one of these clinical features, that is to say arterial thrombosis, venous thrombosis, or pregnancy loss, and at the same time, at least one of the laboratory features. Now, the pregnancy loss in antiphospholipid syndrome is very carefully defined. So it can't be any pregnancy loss. So for example, early pregnancy loss, first trimester, there must be at least 3 successive first trimester losses to qualify as APS. And there must be no other cause. In other words, there can't be a genetic cause which made the person have a miscarriage. So it's very clearly defined what those pregnancy losses can be like. The laboratory features. There are 3 types of tests routinely done: the anti-cardiolipin ELISA, the lupus anticoagulant test, and the anti-beta-2 glycoprotein 1 ELISA. These 3 tests are called the criteria assays. That means that they are within the criteria. As you'll see, there are some other tests which have been developed, but they are not currently within the criteria. And very importantly, these tests can sometimes be positive transiently after infections or after some medications and don't cause a syndrome. So the criteria say the test must be persistently positive on at least 2 occasions, at least 12 weeks apart. But what do we mean by a positive test? And this is an important thing. So in your lab or in my lab, the lab may send you back something saying the test is positive. That just means that it's above the upper limit of normal. That is not positive in terms of the diagnosis of APS. The criteria are quite clear. For an anti-cardiolipin test to be positive enough to diagnose this, it must be at a level over 40. An anti-beta-2-1 ELISA must be above the 99th percentile, and the lupus anticoagulant test is just positive or negative. Now, here's another very important point I want to take away with you. An individual patient may not be positive in all these tests. They may be positive in only one of the tests, or 2 or 3. And the people who are triple positive, who are positive in all 3 of these tests, are the ones who are at the very highest risk of thrombosis. Okay, so everybody in the world is on the slide I'm going to show you now. Every single human being in the world is represented on this slide. So you can see the circles. So some people on the far right here have clinical and serological criteria. In other words, these are the people who really definitely have APS. On the left-hand side are almost all the people in the world, and hopefully everybody who's listening to my talk, no clinical features, no serological features. They're perfectly healthy people. So on the left, we have the healthy people. On the right, we have the people with true APS. But what about those 2 circles in the middle? At the bottom, some people who have the positive antibody test, but they haven't had any features. At least they haven't had any features yet. Are they one day going to move to that circle on the right and have APS? And at the top, there are people who have clinical features which are similar to APS, but they don't have any antibodies. So what are they? Are they people who might be going to get APS one day? So in my talk, I'm going to talk about 6 imaginary patients, people who I've made up to describe all of these scenarios. And here are my patients. Patients A, B, and F are going to be people who actually have both clinical and serological features. Patients C and D are people who are carriers of the antibodies, but they haven't had any clinical features. And patient E is somebody with the clinical features, but no antibodies. Now, when I first gave this talk in the United Kingdom, the series Game of Thrones was in all the news because it was the final series. Everybody was very excited about it. So I thought rather than just give these patients letters, I would name them after the key characters in Game of Thrones. And I told the organizer of this, and I said, well, this probably won't be good for India. And they said, no, we love Game of Thrones in India. Everybody watches it. Keep it. So my first patient, Tyrion A, a 45-year-old man. Remember, this is an imaginary patient. He's not real. He's presented with a cerebral infarct confirmed by imaging with weakness on one side of his body. Okay. His blood results, he's got positive IgG-ACL. He's negative for lupus anticoagulant, and he's anti-beta-2-1 negative. So he's only single positive, right? So the question is, does this man need anticoagulation, and what intensity of anticoagulation does he need? Yes, the answer is yes. He must have anticoagulation. There's very strong evidence from trials and cohort studies that anticoagulation is much better than aspirin to prevent a subsequent thrombosis. So in somebody who has a proven thrombosis and antiphospholipid syndrome, you must anticoagulate them. That's what the evidence says. And there has not been shown that there's any safe time to stop. A question which often comes up is, what if the antiphospholipid tests become negative at some time in the future? And historically, the data has said, even if that happens, if you stop the treatment, the person is still having a high risk of thrombosis. There has actually been a recent paper from Italy that I read which challenged that and found some patients with lupus in whom the antibodies became negative and they stopped the anticoagulation. But there were only 13 patients, so I don't think that's enough to change our paradigm. So currently, people never stop or they have long-term anticoagulation. Now, I said that single positivity was a low risk group, but in this scenario, in the scenario of Tyrion A, that doesn't matter at all because he's had a thrombosis. We're not trying to predict his risk of thrombosis. We know this is a guy who has thrombosis. So single positivity doesn't matter. You're not trying to assess the risk here. Okay, so we accept that he needs anticoagulation, but how high should the INR be? Should it be a moderate intensity, INR 2 to 3, or high intensity, INR 3 to 4? actually the RCTs that have been done have not shown any strong benefit of high intensity. However, having said that, even though the RCTs don't prove it, many people in standard practice do opt for high intensity INRs of 3 to 4 in people with arterial thrombosis. And the reasoning is that the consequences of a recurrent arterial thrombosis are worse. So imagine your patient has had one leg DVT and you give a moderate intensity anticoagulation, they have another one. Well, you know, it's not too bad. If somebody's had a stroke and they're paralyzed on one side and then they have another stroke, that could be really, really bad. So people worry more often about arterial thrombosis, and that's why they use higher intensity. Now, there have been some systematic reviews of this area. Two published in the middle of the last decade are ones I really like, Lim and Ruiz Irastorza. And these reviews had slightly different methodology. You can see that Ruiz Irastorza included cohort studies as well as RCTs, but actually they agreed on many things. And their suggestions haven't really been superseded. You should always anticoagulate patients with APS following a thrombosis. The anticoagulation should be indefinite. And they said you should have a higher INR for arterial thrombosis. What about the new direct acting oral anticoagulants? This is a question which is very often asked. So these DOACs are things like rivaroxaban and apixaban and so on. Now, these drugs have been used very widely in other forms of thrombotic disease, for example, atrial fibrillation, and seem to be as good as heparin and warfarin. So certainly about 5 years ago, there was great hope for these drugs in antiphospholipid syndrome, because warfarin is tricky to use. It can be difficult to get people to the right INR. The INRs go up and down very wildly. People don't like taking them and so on. With rivaroxaban, you don't have to have regular blood tests. It's very predictable. It interacts less with other drugs. It seemed like a really high hope. So people did studies, trials comparing rivaroxaban to warfarin in APS. Two main studies have been published. The RAPS study, done in the United Kingdom with 110 patients, was a non-inferiority study. It was only trying to prove that rivaroxaban was as good, not better, and the outcome measure was a laboratory outcome measure, the generation of thrombosis in a laboratory assay. So in this study, about 54 versus 56 people in the rivaroxaban and warfarin groups, nobody at all got a thrombosis. Not in either group did anybody get a thrombosis. So you can't really tell which is better, but the laboratory outcome measure was equally good in both. So the RAPS study said, yes, we can use rivaroxaban instead of warfarin. But the TRAP study, which was done in Italy, reached a radically different conclusion. The TRAP study was different because they only included the highest risk patient, the triple positive patients. The RAPS included even lower risk patients as well. But the TRAP study was bad news for rivaroxaban because there were excess bad events, adverse events in the rivaroxaban group, considerably higher levels, as you can see in this slide, thrombosis, myocardial infarction, and major bleeds. And therefore, because the rivaroxaban group was doing so badly, they stopped the trial. The trial was stopped by the safety committee. And because of that, in Europe, the European Medicines Agency and the MHR in the UK has advised against these DOACs in APS. It's advised against using them. Now, there is some controversy because some people say that the PENGO trial, the TRAPS trial, only proves that for the high-risk patients. So you can still use it in low-risk patients. Some people are arguing that. But currently, people are quite reluctant in the United Kingdom to use these drugs in APS at all. But certainly, we shouldn't be using them in arterial thrombosis, triple positive patients. Okay, here's my second imaginary patient, Daenerys B. Now, she's 30 years old. She's had 3 previous miscarriages, including a late trimester miscarriage. So this fulfills the pregnancy criteria for APS, and she's had a previous thrombosis. So she's definitely got the clinical criteria, and she's got laboratory criteria. In fact, she's double positive. So she comes to see you, and she wants to try another pregnancy. She wants to get pregnant. Can we help this lady get pregnant? First, we've got to stop her warfarin. Remember, she's on warfarin because she's had a thrombosis. She's got APS. I said you have to give her anticoagulation. So you've got to stop it because warfarin is teratogenic. Now, the evidence base for this is subcutaneous heparin daily and aspirin 75 milligrams daily throughout pregnancy. It's ideal to manage this lady with an obstetrician in a high-risk pregnancy clinic because it is a high-risk pregnancy. But the good news is, with this sort of management, heparin and aspirin, the live birth rate is above 70%. That's a really good live birth rate, much better than before this treatment. But it still could be a complicated pregnancy. The patients can get things like postpartum and hemorrhage, intrauterine growth retardation. They need to be watched carefully. But overall, the outcomes are good. And this meta-analysis that I've cited here will tell you all the data about it. Here's a third patient then, Thursday C. Now, she's 35. She's newly diagnosed with SLE. The reason I'm putting that in is that often the people who are found to have the antibodies without any clinical features, they found that to have them in accidentally because they've got SLE and they're being screened. Many lupus cohorts do the antiphospholipid test as standard, even if there are no clinical features of the syndrome. So this is one of those ladies. She's got SLE and they found out by doing the test that she's positive for antiphospholipid antibodies. Indeed, as you see at the bottom, she's triple positive. She's in that high risk group. But nothing's ever happened to her. She's never had any history of thrombosis or any history of miscarriage. What should we do? Should we treat her with anything? Remember, she hasn't actually had a thrombosis. So this is all about the calculation of risk. And my approach to this would be firstly to ask a hematologist to collaborate, because they're very good at calculating these risks, and they include other factors such as factor V Leiden and so on. Don't forget to do the really, really simple things, the things which don't involve drugs at all, like tell the patient not to smoke, tell them to avoid the combined oral contraceptive. If they fly, maybe they could wear stockings and so on. Look for multiple risk factors. Now, with respect to the APL themselves, the higher the titer of the APL and whether they're double or triple positive makes them higher risk. So you put all these factors into your calculation. Now, at the end, you come up with an overall risk. And if it's high, you could consider anticoagulation. But otherwise, you might consider aspirin. So the higher titers are really important because studies have persistently showed that the high titer APL patients are at the highest risk of thrombosis. And by the way, beware of papers which purport to be about APL positive patients, but when you look at the small print, their APL definition doesn't conform with the definition of APS that I gave you. So they're not talking about people who are above 40, they're only weak positive. Beware those papers. Higher titers mean higher risk. Furthermore, IgG is worse than IgM. So if they report only IgM anticardiolipin, that's not as bad as IgG anticardiolipin, and double or triple positivity is definitely worse. For example, this paper from a specialist center in Italy showed that in triple positive patients, even though they were being treated in a specialist center, there was a high risk of thrombosis in the next 10 years. So these are the highest risk patients. So this young lady, she's triple positive, and she's got high titer, she's got all the bad risk factors, but she's never actually had a thrombosis. So we're going to advise her not to use the combined oral contraceptive. We're going to strongly advise her not to smoke. We're going to liaise with hematology. And on this profile, some hematologists would recommend anticoagulation for this lady, and many would recommend aspirin. Why is that? Well, again, there's not really any randomized controlled trial evidence. So there's only one RCT being published comparing aspirin with placebo in this sort of patient, the asymptomatic seropositive patient, and it didn't show a benefit of aspirin, but meta-analysis of cohort studies have been done. Now, the first meta-analysis suggested that the higher the quality of the study, the less likely it would be to show a benefit of aspirin. But then the author, Laurent Arnaud, went back to the people in those high cohort studies and said, can you share with me the primary data of the patients? So this is a very unusual thing for him to do. He said, I've read your papers, but I want to see the primary data. And to their credit, the authors gave him the primary data. And he used that to allow for factors such as smoking and other risk factors. And when he allowed for that, the evidence was that low-dose aspirin actually halved the risk of thrombosis in APL-positive patients. So Arnaud himself now recommends using aspirin in the high-risk triple-positive patients, even if they haven't had a thrombosis. Here's my next patient, Santha D. Now, she's another patient, asymptomatic. She's been found to have the APL coincidentally. She hasn't had thrombosis and she's never been pregnant. So in this case, we're not trying to prevent thrombosis, we're trying to help her to have a baby. And she's only single positive, you see, she only has a lupus anticoagulant. So what are we going to do for this lady? So remember that the patient who had had a history of pregnancy loss, I said heparin and aspirin. Are we going to put this lady on heparin and aspirin? How do you calculate the risk? Well, you can use the same factors, for example, triple positivity, high titer, but there is no evidence to support use of heparin in somebody who's never had a pregnancy loss. Remember, the risk of thrombosis postpartum might be raised in these patients. Some use aspirin, and the lupus anticoagulant, which this lady has, may be the best predictor of adverse events. So I think that somebody like this, often aspirin would be used because she's lupus anticoagulant positive. But remember, pregnancy is a kind of special case because pregnancy is a really all or nothing thing. You can't partly lose a pregnancy. You've lost it or you haven't lost it. So it depends on the circumstances of a lady. If this is a young lady, regular periods, very likely to be able to get pregnant again, that's one thing. But if she's 44, she's trying for a baby, her partner's got a low sperm count, this might be her last chance. And in that circumstance, often people will give everything, heparin and aspirin, because the patient says, give me everything. This is my last chance. I want to try as hard as I can. So it is a very personal decision for the woman. Next, John E. Now, he's a 29-year-old man. He has suffered DVTs and PEs. He's got libido irregularis and migraine. So he looks exactly like an APS patient clinically, but we do his tests. They're always negative, always negative. There are some patients like this who clinically resemble APS, and yet the tests are negative. Now, Hughes and Kamashita at St. Thomas's have come up with the theory of seronegative APS with negative tests. And this has led to a lot of controversy. How they define it is the typical clinical features, including non-thrombotic ones, with repeatedly negative tests. Now, some people object very, very strongly to the term seronegative APS because they said, hang on, you guys, you defined APS as having to have the positive test. You can't now change the definition. You said the test has to be positive. You can't now say it doesn't have to be positive. And furthermore, you've told us for years and years that the antibodies cause the disease. So how can you have the disease without the antibodies? Stop talking about seronegative APS. And the answer, I think, is that the tests aren't perfect. There are some antibodies which don't show up in our common tests. Here are some new tests that have been developed, which are not used in standard practice. You can see IgA antibodies. We're only measuring IgG and IgM normally. There are antibodies to prothrombin, to other phospholipids, and to part of beta-glucoprotein, only domain 1. And we ourselves in our lab did a test. We did a collaboration with St. Thomas's. They sent us 40 patients who they had seronegative APS and 40 patients who they had said had seropositive APS. They sent us the samples. We were blinded to the samples. We tested them in the anti-domain 1 test, and some of those SNAPS test patients were positive. So I believe that some of these patients with so-called seronegative APS actually have some antibodies. But actually, this is more a semantic argument for clinicians. It doesn't matter to the patient, because this patient clearly is really, really high risk of thrombosis. He's had multiple DVTs and PEs. He's probably going to have long-term anticoagulation, whether or not we call him APS or not. So it may not matter to the patient as much as it matters to us. My personal view is I don't have a strong view. I'm not really one of those who gets very upset about the concept. I think we should keep an open mind. And my final patient, Aria F, a 30-year-old woman, gangrene of multiple fingers, pulmonary emboli, stenosis of the abdominal aorta. This is what is called the catastrophic antiphospholipid syndrome. It's very rare. Antiphospholipid syndrome itself probably occurs in less than 1 in 1,000 people. Catastrophic APS is only 1% of those people. So you can see how rare it is. Even in a specialist center like ours, we hardly see it. The definition is that 3 or more organ systems or tissues at the same time must be involved with thrombosis, and you should be able to confirm that by histology, and it's happening very, very quickly. So it really is catastrophic. Those of you who've seen these patients, it really, the term catastrophic is absolutely correct. And there is a very high mortality, greater than 40% mortality. If you see a patient with catastrophic antiphospholipid syndrome, if your patient is alive at the end, that is a good outcome. And what can we do for these patients? So in general, we throw everything at these patients. So a combination of anticoagulation, high dose, therapeutic dose, intravenous steroids, intravenous immunoglobulins, rituximab, and sometimes even plasma exchange can be used. So usually at least 4 of these things at the same time will be used, and even that might not be enough. There has been a suggestion that, for example, if one limb is very necrotic, that limb is going to be shooting off more emboli and so on, and amputation is actually good for the patient. Well, it's very rare that we say amputation is good for any patient, but sometimes it can be life-saving. People can survive the catastrophic antiphospholipid syndrome. I have seen people survive it. They may lose fingers and toes, they may lose limbs. It's a very, very dangerous scenario, and this is the sort of way we treat it. So in summary, I'd like to divide my talk into these 2 different groups. Firstly, the confirmed APS groups, the people who fulfill the criteria. They've had clinical features, they've had serological features. If you want to prevent recurrent thrombosis, there is no dispute. Long-term anticoagulation is the way to go. Many would use higher intensity for arterial thrombosis. DOACs, evidence is currently against them. But if somebody's already established on a DOAC, if they're already taking rivaroxaban, we don't necessarily stop it. We go over the story with them. We say, this is the evidence. What do you think? And many people say, look, I can see that, but I personally like my rivaroxaban. I want to carry on. For pregnancy protection, subcutaneous heparin plus oral low-dose aspirin. For the people who've never had a clinical feature, they're just carriers, we're trying to assess the risk. Is it worth treating them? So consider the titer, the isotype, and triple positivity. Talk to your hematologist. Evidence for aspirin alone, well, it's not definitive, but in the very highest risk group, the triple positive one, I think that there is enough evidence to go for aspirin. High-risk patients may benefit from anticoagulation even if they've never had something before. And in pregnancy, there isn't any evidence for the use of heparin. For lupus anticoagulant positive mothers, maybe aspirin. But if it's a very, very, I mean, all pregnancies are valuable, but if it's a really valuable one, the kind of person who may never have another chance of getting pregnant, I could be persuaded by the patient to use heparin plus aspirin, bearing in mind that even those they could have side effects. It's all about assessing the risk, talking to the patient. Thank you very much.
Thank you, Professor Rahman. I think you've really brought out all the various aspects of antiphospholipid antibody syndrome through the various case scenarios. And I would like to go through the questions which have been asked by the audience. So Dr. Kiran Dudam asks, can we reduce thrombosis risk in high titer APLA patients without any known thrombotic manifestations by giving B-cell depleting therapy?
Okay, it's a good question. There is no proof of that. There is no proof that rituximab does that. Now, it has been shown that the levels of the antibodies can be reduced by B-cell depletion. And there was a trial in the United States where they looked at the non-thrombotic features and didn't show an effect. I think the difficulty with that conceptually is, what would you do? Remember, what you're trying to think of doing is keeping their B cells low for a long, long time in somebody who has no symptoms. You're basically immunosuppressing somebody all the time on the basis of something which might or might not ever happen. So there is not any proof that rituximab should be used for that purpose.
Your comments on complement-directed therapies like eculizumab in catastrophic antiphospholipid by Dr. Kunal Chandwar.
Yeah, so eculizumab, which is anti-C5, is something which hasn't been used very much. We have one patient actually who I've seen quite recently, who's a challenging patient because she has both thrombocytopenia and clotting. So there are these very rare patients whose platelets are low, and also they have a risk of clotting. And the only way in which that lady was balanced was to give her eculizumab, but she's the only person I've seen. There's quite good evidence that it could work, particularly in pregnancy loss. Jane Salmon's group in the United States have shown that the activation of complement within the placenta is a big feature. So there isn't any trial evidence. There's anecdotal evidence in very difficult patients that it can help. And often it's to prevent further attacks of the catastrophic syndrome rather than in the acute attack. But remember, the acute attack of CAPS is such a devastating thing that often people use all sorts of things just to try and get the patient through it.
There's an interesting question by Dr. Kiran Dudam again regarding the presence of antiphospholipid in COVID infection. And so he asks whether we should stop anticoagulation, or does it need to be continued for a long term, on a long-term basis?
So I'm not, so let me just see if I can see the actual question. So this has come up a lot in COVID, because obviously COVID has this increased risk of thrombosis, and some patients with COVID have been found to have antiphospholipid antibodies. So I haven't read much of this literature myself, but what I would say is patients with antiphospholipid syndrome are not themselves at higher risk of COVID, and that they probably already will be on anticoagulation. So I think having COVID doesn't alter the ongoing treatment of somebody with APS. You should continue what's being done. If somebody gets COVID and they have APS even transiently, I think that they would be more likely to get anticoagulation. Certainly here in the UK, people admitted with COVID often get anticoagulation anyway. How long you continue it, it's such a new disease. I don't think any of us really know. I haven't read any guidelines on it, so I can't help you with that, I'm afraid.
Right. I think Dr. Lalit Dugal had asked a question which I wanted to ask as well, that if you had an arterial thrombosis, rather than increase the warfarin or the INR, the target INR, would you like to combine it with aspirin?
Yeah, that's a good question, and some people do that. What we're kind of struggling with here a little bit is that there isn't any trial evidence to say which of those two things is better. There's just not any trial evidence to tell you one way or the other. So what we tend to do here is we work very closely with our hematology team. And the difficulty with trying to maintain a high INR, as many people will know, is in antiphospholipid syndrome, it's really difficult to control the INR. So the INR sometimes varies wildly, even though you haven't changed the warfarin dose. So if you're aiming for 3.5, there might be some days when the INR is 6 and you didn't do anything about it. So people are quite frightened of running high intensity anticoagulation. I personally would be quite in favor of that, combining moderate intensity with aspirin. But my hematology colleagues are more in favor of running people at a higher INR level. And I think what they do is they take into account everything about the patient. So it's quite a personal calculation for each patient. Are they triple positive? Do they have high titers? Have they had multiple thromboses? Was their thrombosis provoked? There's this concept of provoked versus non-provoked. In the new ULR guidelines, very interestingly, they say that if thrombosis was unprovoked in a person with APS, you should continue the warfarin long term. But if it was provoked, if there was a really good reason for it, such as they had a line in, you may be able to stop it after 6 months. So the answer to your question is, I think there's good arguments for both of those things, high intensity or moderate intensity plus aspirin. I like to keep the INR low if I can. Hematologists, who are often braver than we are because they're used to it, in my experience, go for the higher dose anticoagulation.
There are a few more questions, and I think the one of it is on APS nephropathy. Any comments on APS nephropathy treatment?
Yeah, so APS nephropathy is quite a rare cause. It's something which happens relatively rarely. So what happens is that you get microinfarcts, and it presents, unlike lupus nephritis, not with proteinuria, but with reduction in the creatinine clearance and the GFR. And in our cohort, we've got a couple of patients who went into end-stage renal failure due to that alone, APS nephropathy. So it can happen. Can you prevent it by being on anticoagulation? The difficulty is, if you've got somebody on anticoagulation, you probably don't know whether they ever would have got it or not. But once it's reached a level where the creatinine clearance has started to fall, it's very difficult to reverse that even with anticoagulation. So the bottom line is it can happen, it's rare, it can lead to end-stage renal failure.
And just to go with your first example of a 45-year-old male, say he had only the antibody positive, but say he had all the traditional risk factors, premature, early atherosclerosis. What would you do in that situation?
Yeah, I mean, obviously anything which is modifiable, you modify. If he's smoking, he shouldn't smoke. If he's got high cholesterol, let's give him a statin. If he's got diabetes, let's control that. So control everything that you can control. That's what I would say. And then if he's already got atherosclerosis, say he's got a carotid plaque, there isn't actually any proof that anticoagulating him is going to reduce his risk of that getting any worse. So I think that the evidence is in favor of controlling the standard modifiable risk factors rather than anticoagulating as a primary prevention in a single positive patient.
Right. And the perioperative management of patients with antiphospholipid syndrome.
Yeah, so I mean, I think that what happens here is that the anaesthetist and the hematologist and the surgeons work very closely together. So what usually happens is if they're on warfarin, before the operation, the hematologist design a bridging plan. They stop the warfarin, they change them to heparin. They say how long the heparin should be continued before they go back to warfarin. So they need to be anticoagulated for as long as possible before and after, but clearly during the operation, they're not going to be anticoagulated. So usually what happens is they're changed to heparin and they're off heparin for a relatively short period of time. And then they go back to heparin and then to warfarin. So you need input from hematology is the bottom line.
And one question from Dr. Ankur from Dr. Kunal, statins, the role of statins.
Role of statins. Okay, so essentially there's been a lot of interest in statins based on the basic science literature. So for example, we and others have shown that statins can inhibit the effect of antiphospholipid antibodies on monocytes taken from APS. So there is some evidence from basic science that statins could be good. The difficulty here is that there is no evidence from trials about statins. Remember that statins are often contraindicated or at least advised against in young women who want to have children. And that's a big part of our APS cohort. So you're not necessarily going to put those people on statins anyway. There isn't any guideline, including the guidelines I showed you, the EULAR guidelines, which says you should put these people on statins. So there's good basic science reason to think it might work. We haven't really translated that into a guideline or a methodology in patients.
And I think a final question of the role of hydroxychloroquine in primary and secondary APS.
Yeah, so this is another very interesting topic. Again, there's good evidence from basic science studies that hydroxychloroquine might be helpful. It's often used in patients with lupus, people who've got secondary antiphospholipid syndrome, so they're on it anyway due to the lupus. Does it prevent against thrombosis? Certainly not as well as anticoagulation. It can't take the pace of anticoagulation. It can improve symptoms such as tiredness, joint pain, and so on. So in people with primary antiphospholipid syndrome who are on warfarin, but they say, I still feel ill, I still feel tired, I still have joint pain, hydroxychloroquine can sometimes definitely help those people. People have tried to do large trials of hydroxychloroquine in APS, either in pregnancy or thrombosis, and there are trials going on at the moment. The difficulty is you have to have huge numbers of patients in order to show a significant effect of the drug. So in summary, hydroxychloroquine very widely used, in general safe, often used in SNA plus APS, sometimes used for symptomatic control in APS alone, but does not prevent thrombosis. It is not strong enough by itself to prevent a thrombosis or a miscarriage.
Thank you very much, Professor Rahman. And I would now hand over to Dr. Sapan Pandya to take over the final conclusion and the concluding remarks. And thank you everyone for the invitation and the opportunity.
Thank you, Professor Rahman, for removing the clots in our knowledge. I'd also like to thank Professor Mishra for his intriguing talk, Dr. Ranjan, Professor Lisa. I thought today's was one of the best sessions that we've had till now. We discussed that. Also the moderators, Rohini and Amisha, for the excellent moderation. I must thank INTAS, the industry, for today's sponsorship. I'd request all of you to log into the IRA website more frequently to look at the question answers, which we'll try and put up there after having answers from all the speakers who have been left. Also regarding the next webinar, which should be on 28th and 29th of November, and it's on CTDs other than lupus. We are trying to carve out a good program for everybody. And we'll also have a sort of a feedback. We will need a sort of feedback from all of you. We'll put that up on the website also, but you can in the meanwhile, you can send that to me on email, on the secretary's email of the feedback of these programs. Anything you would like, or any suggestions that you have for the webinars. And I think with that, we'd like to end today's session. Good night to all of you and stay safe. Thank you.
Thank you.